All right, so a very good evening, everyone. So I am myself Dr. Rajesh Gubba. I am the general medicine educator on Unacademy platform. So as the NEET PG is coming up nearby, so I have I'm about to take one particular session which includes some last minute revision points which will be very much useful for your upcoming NEET PG exam. All right. So before that, yeah. So let me just give you update regarding the Unacademy batch courses which are about to start from September 1st. On September 1st, Unacademy is starting up with Focus FMGE batch, NEET PG 21 Emergency Room MCQs batch, Target Next 2022 integrated batch, and as well as NEET PG 21 last 3 years previous year questions batch. So these are the batch courses which are starting from the 1st of September. And those students who want to get subscribed to these particular courses, you can use my code, that is MED10, right, wherein you will get an additional 10% discount on your subscriptions, right? And Unacademy also has introduced 1 month subscription package wherein it includes the ultra fast track high yield revision batch, emergency room MCQ batch, NEET PG test and analysis batch, last 3 years NEET PG previous year question batch, COVID test, and as well as the grant test series. And these are the list of grant test series which are being conducted by Unacademy, and they are being started from 4th of August continuing up to 11th of September. So all these particular grant test series will definitely be very much useful for you to crack your upcoming NEET PG exam. And those students who are in first year or second year of your MBBS, this particular subscription will be very much useful for you all through your MBBS, wherein you can crack your prof exams and as well as you can also crack the upcoming NEET PG exam as well. So having said this, let me start this particular session. Okay, so this is a clinical scenario of an individual. A 32-year-old woman sees her physician because she has noticed milk-like discharge from her breast since past 4 weeks. She also states that she has not menstruated in 2 months. The examination reveals galacturia but is otherwise normal. So can anyone tell me what is the clinical diagnosis of this patient? Yes. What is the clinical diagnosis of this patient? So if you see the clinical diagnosis, this is a case of the hyperprolactinemia, right? Very good, Neha. So it is a case of the hyperprolactinemia. And what would be the underlying cause? Most common cause for your pathological causes for your hyperprolactinemia will be prolactinoma, right? Now if you see this question here, what is the common clinical problem with excess prolactin secretion? Can anyone answer this? What is the common clinical problem with excess prolactin secretion? So the common problem will be galacturia and as well as the amenorrhea. So this will be the common clinical problem with excess prolactin secretion. Please remember, that's an important point. Now, why there is amenorrhea? Why there is amenorrhea? That is because of increased prolactin secretion. Right, that is because of increased prolactin secretion that will suppress the luteinizing hormone and as well as the follicle stimulating hormone secretion. That is the reason why there will be amenorrhea in patients with the prolactinoma. Next, what is the mechanism of prolactin causing infertility? So what is the mechanism of prolactin causing infertility? This increased prolactin, right, this increased prolactin will inhibit the luteinizing hormone surge and thereby the ovulation is inhibited. So this increased prolactin, it will inhibit the ovulation and thereby the excess prolactin will cause the infertility, right? So this is a very, very important point. Next, followed by that, is there hyperprolactinemia in men? Yes or no? Can anyone answer this? Is there hyperprolactinemia in men? Yes or no? So hyperprolactinemia is also seen in men, but it is a very rare scenario. And what will happen when there is hyperprolactinemia in men? There will be gynecomastia and very rarely there will be galacturia. Okay, yes, good, Aruna Devi. So then followed by that, what is the most common presenting symptom in men if there is hyperprolactinemia? So the most common presenting symptom in men if there is hyperprolactinemia will be erectile dysfunction and as well as the decreased libido. That will be the common presenting problem. Then followed by that, what are the other causes of the hyperprolactinemia? So can anyone tell me what are the physiological states which will cause hyperprolactinemia? What are the physiological states where there will be hyperprolactinemia? Can anyone answer? Okay, so let me tell you the physiological states where you will have hyperprolactinemia will be, that includes pregnancy, early nursing, exercise, sleep, stress, and as well as the nipple stimulation. So these are the physiological states where the individual can have the development of the hyperprolactinemia, physiological states. Now, definitely you should know what are the pathological causes for hyperprolactinemia. So, if you take the pathological causes, that includes cirrhosis of liver, chronic renal failure, hypoglycemia, seizure disorder, prolactinoma, and then we have certain drugs. Right? Then we have certain drugs. So, what are those drugs? I will discuss that in detail. So in chronic renal failure, what will happen is the prolactin is not being excreted out, and that will make the individual to develop hyperprolactinemia. All right, next. Then followed by that, yes, what are the drugs causing hyperprolactinemia? So drugs causing hyperprolactinemia are those which will inhibit. Hyperprolactinemia can also occur with inhibitory action of the dopamine. Now, can anyone please tell me what are the drugs which will cause hyperprolactinemia? Yes. So, those are the drugs which will block the dopamine synthesis. Examples, phenothiazines and as well as the metoclopramide. And dopamine depleting agents like alpha-methyl dopa and as well as the reserpine. Then finally, we have tricyclic antidepressants, narcotics, cocaine, selective serotonin reuptake inhibitors, risperidone. These are all the conditions where you have increase in the prolactin levels. So these are the drugs which will cause hyperprolactinemia. Next, followed by that, how do macroadenomas cause the hyperprolactinemia? What do you understand by this word macroadenoma? If the size of the tumor is like more than 10 mm, we use the word macroadenoma. See, what these macroadenomas they do is they obstruct the pituitary stalk. Right, they obstruct the pituitary stalk. So once they obstruct the pituitary stalk, they block the dopamine transport from the hypothalamus to the anterior pituitary. So thereby what will happen now? There will be increase in the prolactin levels. So macroadenomas, they cause hyperprolactinemia by obstructing the pituitary stalk. So please remember, that's a very important point. Then followed by that, how does primary hypothyroidism cause hyperprolactinemia? Can anyone answer this question? Yes. So how does hypothyroidism cause hyperprolactinemia is whenever there is hypothyroidism, that too primary hypothyroidism, there will be increase in the TRH, that is thyroid releasing hormone. So once there is increase in your TRH, that is thyroid releasing hormone, that can cause elevated prolactin levels. Okay, so increased TRH will not only elevate the TSH, will also increase the prolactin as well. So please remember, this elevated TRH is the one which is responsible for elevated prolactin levels. Then, what will be the clinical presentation of prolactinoma in women? See, clinical presentation of prolactinoma in women, they can have the following features: menstrual abnormalities in the form of amenorrhea and oligomenorrhea, and then osteopenia, osteoporosis, and galacturia. And in long-standing cases of prolactinoma in women, those individuals, they can also have infertility and gynecomastia in women. So this will be the clinical presentation of prolactinoma in women. All right, next. Now, then followed by that, what is the clinical presentation of prolactinoma in men? So if you take the clinical presentation of prolactinoma in men, that includes loss of libido and as well as the erectile dysfunction, gynecomastia, and as well as infertility. So that will be the clinical presentation of prolactinoma in men. So men, if you observe, Men, if you observe, they do not develop galacturia, very rarely to have galacturia, right? Next, then followed by that, how do you diagnose prolactinoma and hyperprolactinemia? See, the diagnosis of prolactinoma and as well as hyperprolactinemia is mainly by estimation of the prolactin levels. So if you take the normal prolactin levels, can anyone tell me how much is the normal prolactin levels? Yes, the normal, yes. So the normal value of prolactin in men will be less than 20 nanograms per ml, whereas in non-pregnant women, it is less than 25 nanograms per ml, and in pregnant women, the value will be around 80 to 400 nanograms per ml. So this will be the normal prolactin levels, right, according to the gender, and that too in females, whether the female is a non-pregnant or a pregnant female. All right, then followed by that, yes, at what prolactin levels do you suspect the prolactinoma? At what prolactin levels do you suspect prolactinoma? So right, so when the prolactin levels are more than 100 nanograms per ml, it probably suggests pituitary adenoma. But when the prolactin levels are more than 200, that is highly suggestive of prolactinoma. It confirms the prolactinoma, right? It confirms the prolactinoma when the prolactin levels are more than 200 nanograms per ml. Okay, so at what prolactin level do you suspect prolactinoma? At more than 200 nanograms per ml. That should be your answer. Then how do you manage the prolactinoma? So please remember, medical management is the first line treatment for prolactinoma. So medical management will be the first line treatment. And in refractory cases, what will be the management? In refractory cases, what will be the management? Right. So in refractory cases, surgical resection of the tumor has to be done. So if you take medical management, that includes Cabergoline or bromocriptine has to be given. Right, Cabergoline or bromocriptine has to be given. Both of them, they are dopamine agonists and they will inhibit the prolactin release. Then followed by that, if you see what is the efficacy of the Cabergoline? So efficacy of Cabergoline is that about 90% of patients treated with Cabergoline have a drop in prolactin to less than 10% of pre-treatment levels. That is the efficacy of the Cabergoline. Then followed by that, you should know when is the surgery required in prolactinoma. So as already I have mentioned, whenever the individual is refractory to medical management, or when the size of the adenoma is not reducing with the medical management, that is the point when surgery is required. That is the point when surgery is required. And what is the name of that particular surgery? That is transphemoidal surgical resection of the pituitary gland. Okay, then when do you use radiation therapy? So when the individual is refractory to both, right, when the individual is refractory to both drug therapy and as well as surgery, that is the point when we need to do the radiation therapy. Okay, so that is about the indication of radiation in patients with the prolactinomas. Then the other endocrine disorder will be, which is important for your upcoming NEET PG exam, is your hyperthyroidism. Okay, so please tell me, what is the most common cause for hyperthyroidism? Most common cause for hyperthyroidism will be, Graves' disease. Graves' disease is the most common cause for hyperthyroidism. Now, what is the pathogenesis in Graves'? What is the pathogenesis in Graves'? So, if you see pathogenesis in Graves', it is an autoimmune disorder. Right? It is an autoimmune disorder where you have thyroid stimulating immunoglobulins which are being produced in excess quantities. That will be the important pathogenesis in the Graves' disease. Then followed by that, what are the causes of intrinsic thyroid autonomy? Right, apart from Graves', intrinsic thyroid autonomy causes which cause hyperthyroidism includes the goiter. Which particular goiter is that? Toxic adenoma. Then followed by that, the toxic multinodular goiter. which is nothing but Plummer disease. Now, can anyone tell me what will be the very important features of the Plummer disease? What will be the important features for the Plummer disease? Can anyone answer this? What are the important features of the Plummer disease? Any one of you? Right. So if you see the important features of the Plummer disease. So in patients with Plummers, they have the development of arrhythmia and as well as the congestive heart failure. So Plummer disease, it is a toxic multinodular goiter, right? And it is non-autoimmune disease of the elderly individual, where there is development of arrhythmia and congestive heart failure. So that is what is your Plummer disease. So please remember, it's a very important question. Now, what are the causes of transient hyperthyroidism? Can anyone tell me what are the causes of transient hyperthyroidism? So, if you see the causes of transient hyperthyroidism can be seen in subacute thyroiditis, which is painful, or lymphocytic thyroiditis, that is painless. So these two are important causes for transient hyperthyroidism. Subacute thyroiditis, which is painful, and lymphocytic thyroiditis, which is painless. Okay, right. Now, yes, Kambale, you are telling about the iron deficiencies. Plummer, that Plummer is different from iron deficiency Plummer, what you are answering, right? Both are different, both are not same. Okay, then what are the drugs that will cause hyperthyroidism? Can anyone answer? What are the drugs which will cause hyperthyroidism? Any one of you, please. Drugs causing hyperthyroidism. Yes, drugs causing hyperthyroidism. So, if you see the drugs causing hyperthyroidism, they include amiodarone, right? Amiodarone, that is class 3 antiarrhythmic drug, then followed by that alpha interferon and lithium. These are the important drugs which can cause the hyperthyroidism. Then followed by that, what are the agents with excess iodine causing hyperthyroidism? So the agents with excess iodine causing hyperthyroidism, they include the iodine containing contrast agents, right? They include iodine containing contrast agents. So these are the agents with excess iodine that will cause hyperthyroidism. Now, what are the extrathyroid source of the hormones? The extrathyroid source of the hormones will be ectopic thyroid tissues. What are the examples of ectopic thyroid tissue? That will be your stroma ovary. That will be extrathyroid source of your thyroid hormone. Then followed by that, what is secondary hyperthyroidism? Secondary hyperthyroidism, it means it is a scenario where there is increase in the quantity of TSH, and that will be from thyrotroph type of pituitary adenoma. That is what is called as the secondary hyperthyroidism. Now, this is an image showing the presence of pretibial myxedema in a case of the Graves' disease. So this can be asked as an important image based question in Graves. Then, what are the features of the Graves' disease? So if you see the features of the Graves' disease, mainly the features include the development of diffuse goiter, exophthalmos, and as well as dermopathy. So that dermopathy is nothing but your pretibial myxedema. Now, what is the age commonly where you will have this particular Graves? Age, if you see, very commonly it is less than 50 years, right? Graves, very commonly it is seen around less than 50 years. Then, what is the genetic component in the Graves' disease? So if you observe the genetic component in the Graves' disease, a person is more likely to be affected if they have family member with the same disease. So genetic component is definitely there in the Graves' disease. Then, what are the triggering factors for the Graves? The triggering factors in the Graves, if you observe, that includes stress, infection, and as well as the pregnancy. These are the triggering factors for the Graves. Then followed by that, what are other associated autoimmune disorders in Graves? Always remember, the autoimmune disorders, they are associated with one another. In Graves, the associated autoimmune disorders, they include type 1 diabetes mellitus and as well as the pernicious anemia. These two are the associated autoimmune disorders with Graves. Now, what is the risk factor that worsens the exophthalmos? So the risk factor which worsens the exophthalmos will be smoking. Smoking causes increased risk of disease and may make the exophthalmos worse. Then followed by that, how is thyroid gland in patients with the Graves disease? So thyroid gland, if you observe, it is large and it is painless. So it is a painless enlargement of thyroid gland that is you will observe in the Graves disease. Then followed by that, what are the neurological manifestations in Graves? There will be excessive excitement, right? Nervous system in the form of nervousness, emotional inability to sleep and as well as tremors. That will be the neurological manifestations that you will observe in Graves. Then followed by that, what will be the cardiovascular manifestations in Graves? Cardiovascular manifestations in Graves, that includes the development of the hypertension, atrial fibrillation, palpitations, congestive heart failure, high output heart failure. So this will be the cardiovascular manifestations in Graves. Then what will be the GAT manifestations in Graves? That will be in the form of diarrhea, right? Next, what will be the metabolism in Graves? So there is increased metabolism in Graves, there is increased basal metabolic rate, and due to which there will be heat intolerance, profuse sweating, weight loss. This will be the metabolism in patients with the Graves. Then followed by that, what will be the musculoskeletal manifestations in Graves? Musculoskeletal manifestations in Graves, that includes proximal muscle weakness. That will be the musculoskeletal manifestations in Graves. Then what will be the ocular signs in Graves then? Ocular signs in Graves, that includes staring, infrequent blinking and as well as lid lag. That will be the ocular signs in Graves. And what will be the menstrual irregularities in Graves? That menstrual irregularity will be in the form of oligomenorrhea. That is what you will observe in Graves. Then what will be the skeletal manifestations in Graves? That includes osteoporosis and hypercalcemia. And why is that? Because increased thyroid hormone will increase the osteoclastic activity. Then finally, what are the skin manifestations in Graves? Skin manifestations include the presence of warm moist skin. There can be palmar erythema along with fine and silky hair in hyperthyroidism. So that will be the skin manifestations in Graves, right? So these are some of the nutshell points in your endocrinology, right? So this is some quick recap session. And again at 8:45 right now, I have one important clinical based session on Unacademy platform. So you can follow me there for the clinical based questions on the general medicine. And with this, I'll wind up this particular short session of some quick recap points which are very required for your upcoming NEET PG exam. Thank you very much.